Hi, all, and welcome to Professor Truelove's Concepts for Nurses series. And I am Professor Terry Truelove. In this episode, we continue our study of heart failure. But in this episode, we will concentrate on symptoms and available therapies. Sources for this episode include Iggy's Medical Surgical Nursing, as well as Soul's Introduction to Critical Care Nursing. Risk factors for causing heart failure include coronary artery disease, age, hypertension, diabetes, smoking, obesity, African American ethnotypes, a history of valve disease, and hypervolemia. If the heart failure is related to decreased cardiac output, this can be caused by coronary artery disease, cardiomyopathies, rheumatic fever, and endocarditis. If the cause is because of increased cardiac workload, this could be caused by hypertension, valvular disease, anemias, and congenital heart defects. There are some non-cardiac causes, including volume overload, hyperthyroidism, and fever and infection. To differentiate the different types of heart failure, it is important to look at the symptomology. Remember, with systolic heart failure, this is a loss of contractility which leads to the loss of cardiac output. And in diastolic heart failure, this is decreased filling or preload. This means the effect from the left ventricle will mostly be felt in the lungs, while in the right ventricle, those effects will be seen mostly in the peripheries. Another way to differentiate heart failure is between acute and chronic. For instance, the difference between an acute MI causing low cardiac output and chronic cardiomyopathy causing chronic and decreased cardiac output. Another way to differentiate is the high output versus low output. Hypermetabolic states such as sepsis can cause a type of high cardiac output heart failure. That is, although the cardiac output is adequate, the tissues do not get adequate oxygenation and nutrition. Symptoms for heart failure include difficulty breathing, swelling of the feet and legs, an overall lack of energy, difficulty sleeping because of breathing problems, a swollen abdomen, decreased appetite, a cough with frothy sputum, increased nighttime urination, confusion, and impaired memory. Other significant clinical findings include orthopnea, dyspnea, tachypnea. Now, in these patients, you may hear crackles, wheezes, rhonchi, or all three adventitious breath sounds. You may notice the use of accessory muscles when breathing, the presence of cyanosis, and a cough with frothy, sometimes a bloody sputum, cool, clammy skin, an extra heart sound that is an S3 heart sound, tachycardia, and the presence of hypertension. Left heart failure typically manifests itself with dyspnea, that is PND, orthopnea, and exertional dyspneas. Left-sided heart failure causes cyanosis. There will be a cough with wheezes and crackles. Central nervous system effects include fatigue, anxiety, and restlessness and confusion. There will be tachycardia and elevated wedge pressure as measured in the pulmonary artery, and left heart failure will eventually lead to right-sided heart failure. Symptoms for right-sided heart failure include fatigue, weakness, lethargy, GI distress, and anorexia. Weight gain from ascites, liver and spleen enlargement. There can be jugular vein distension, dependent edema, hepatomegaly, and you may not see signs of left heart failure when the patient has right-sided heart failure. If this does occur, this is known as Cor Pulmonale. It is right heart failure without left heart failure. It is caused by unusually high pulmonary pressures that are caused by lung diseases such as COPD. It causes an enlarged right ventricle. Complications associated with heart failure include the presence of pleural effusion, that is, fluid in the pleural space, atrial fibrillation with the possibility of thrombus formation, other lethal arrhythmias including sudden death from ventricular fibrillation, hepatomegaly and liver failure, and renal insufficiency and failure, which is known as cardiorenal syndrome. The specific diagnosis of heart failure is assisted by the signs and symptoms to determine the underlying cause. Also, use a 12-lead ECG and visual imaging via chest X-ray, 2D echocardiogram, or transesophageal echocardiogram reveal the structural changes associated with heart failure, including the enlargement of the myocardium and congestion within the chest. Diagnostics used to determine heart failure include labs such as a complete blood count, which over time will show hemodilution, urine analysis, which will show over time renal insufficiency, electrolytes, blood urea nitrogen, creatinine and glucose, fasting lipid profiles, liver function tests, thyroid stimulating hormones, cardiac enzymes, B-type natriuretic peptides, and arterial blood gases. BNP will be grossly elevated with heart failure. That is, it will be measured in the tens of thousands. Cardiac enzymes may be elevated without showing signs of myocardial infarction. Arterial blood gases will reveal gas exchange problems. Heart failure inevitably progresses to a worse and worse state. So the treatment, beginning from the less severe and progressing to most severe, include initially lifestyle changes. In other words, more activity, less smoking, and dietary changes. Hypertension control can help delay the decreased cardiac output. Treating the patient with ACE inhibitors, especially those with a previous myocardial infarction or who currently have either diabetes or hypertension or both. If the patient has done all of the above and still progresses, you need to add beta blockers to the ACE inhibitor. At this point, it may be important to consider cardiac surgeries to correct any deficits. In other words, for ventricular hypertrophy or ventricular remodeling. The patient may also begin to benefit from the use of diuretics as a way to unload the myocardium. The patient will now begin to benefit from inotropic medications such as digoxin. The patient should start having fluid and activity restrictions for extra fluid and for the dyspnea that accompanies heart failure. You now need to start combining the above medications with assisted devices such as ventricular assist devices or intra-aortic balloon pumps, both of which decrease afterload and increase coronary artery perfusion. Again, increasing myocardial oxygen supply and decreasing myocardial oxygen demand. Continuous inotropic infusions can be given here. This may lead to a cardiac transplant, or if a cardiac transplant is not available or not realistic, end of life, that is palliative care, should be considered because the outcome for untreated heart failure is death. Putting all of the elements of heart failure together, you should know that heart failure is common in the elderly and after cardiac diseases or conditions. Diagnosis is confirmed by imaging, laboratory diagnostics, and hemodynamic profiles. An echocardiogram can suggest the etiology of the type of failure. Diuretics are used for acute relief of dyspnea and for chronic management of fluid overload. By the way, furosemide is the medication of choice for dyspnea related to pulmonary edema. The team should determine events that preceded the acute decompensation in order to best serve the patient, and the medications used for heart failure include ACE inhibitors, angiotensin receptor blockers, beta blockers, diuretics, and inotropes. That does conclude this episode concerning heart failure. However, there are more episodes about cardiac functioning. I hope you learned a little bit. I hope you want to come back and listen a little more, and if you do, I'll see you then. Take care.